need to support intrathoracic tracheal stenosis. Tracheal stenosis when the cervical or thoracic trachea cannot be repaired, and a cervical trachea that cannot be reconstructed. Made of flexible medical-grade silicone, the safety tube is of sufficient density and thickness to support a reconstituted or reconstructed trachea, and yet soft enough to preclude injury to the lining or supporting structures of the trachea or subglottic region. The ends of the intraluminal portion are tapered to help prevent injury due to asynchronous motion between the ends of the tube and the tracheal mucosa. Mucus and crust do not readily adhere to the very smooth inner surface. The tube is widened by the curvature at the junction of the intraluminal and extraluminal portions. This design adds support to the anterior tracheal wall at the tracheotomy site and facilitates suctioning. The safety tube is designed to maintain an adequate airway, as well as to provide support in the stenotic trachea, which has been reconstituted or reconstructed. Our exclusive design of ridges and grooves along the extraluminal limb of the safety tube allows a ring washer to be attached, significantly reducing the possibility of accidental posterior displacement. All Montgomery safety tubes are supplied as a set, which includes 2 ring washers and a plug. You will note that there are 2 longitudinal grooves on the superior and inferior aspects of the extraluminal portion of the safety tube. These grooves distinguish the safety tube from the silicone tracheal cannulas, which have only 1 groove on their inferior aspect. The intraluminal portion of the safety tube, which is to be directed inferiorly, is crimped and grasped with a hemostat. This portion of the safety tube is inserted by way of the tracheotomy. As soon as it is intraluminal, the hemostat is released and applied to the opposite intraluminal portion. Once the intraluminal portion is inside the trachea, the safety tube is grasped and pulled anteriorly. In so doing, the intraluminal portions snap into place. To prevent loss of air or anesthesia through the upper intraluminal portion of the safety tube, a closed system can be created. The 3-way stopcock is attached to a Fogarty-type catheter and then to the syringe. The stopcock is positioned so that the air will pass from the syringe to the balloon at the end of the catheter. It is then adjusted so that air will remain inside the balloon when the syringe is released. The catheter is introduced into the upper intraluminal limb of the safety tube and inflated. The endotracheal tube is inserted into the extraluminal portion of the safety tube and connected to anesthesia tubing, which is passed off to the anesthesiologist, who will now have a closed system with a distal trachea and lungs. The balloon is tested prior to its insertion into the safety tube. The catheter is inserted into the upper intraluminal portion. The balloon is inflated and the stopcock closed. An endotracheal tube is inserted into the extraluminal portion of the safety tube and a closed system is achieved. Suctioning of the safety tube is quite simple. The extraluminal portion of the safety tube is tilted inferiorly or superiorly in order to direct the catheter. Suctioning is being accomplished following insertion of the safety tube first in a superior direction and then inferiorly. It is not necessary to insert the catheter beyond the end of the intraluminal portion of the safety tube, for this will serve only to irritate the mucous membrane and initiate a cough reflex. As the safety tube is pulled from the trachea, the upper and lower intraluminal limbs buckle towards each other. It instantly springs back to its original shape. The ring washer is removed from the external limb of the safety tube. A finger is placed above and below the extraluminal limb of the safety tube, and firm pressure is exerted posteriorly. The external limb is pulled anteriorly. An endotracheal tube is inserted as the patient recovers from general anesthesia. The Montgomery safety tube is available in 4 styles: pediatric, standard, thoracic, and extra long. The original 4200 series standard safety tubes have been producing successful results in tracheal repair for many years. All Montgomery safety tubes are constructed of flexible medical-grade silicone, designed to provide comfort for the patient. The standard safety tubes are available in sizes from 10 millimeters to 15 millimeters outside diameter. The 3200 series pediatric safety tubes feature an angled extraluminal limb to facilitate airway management. The intraluminal limbs can be shortened if necessary. The pediatric safety tubes are available in sizes 6, 7, 8, and 9 millimeters. The 5200 series thoracic safety tube has been designed to provide all the advantages of a safety tube with an extra long limb for thoracic applications. As a life-preserving device, it can be kept in place for many years while stenting thoracic tracheal stenoses, which cannot be repaired surgically. The thoracic safety tube is available in sizes 10 through 15 millimeters. The 6200 series extra-long safety tubes are designed to provide the surgeon total freedom to customize the intraluminal limbs to any desired length, either at our facility or by using the CK1000 customizing kit. The extra-long safety tubes offer solutions for distal stenoses and other problem cases while providing all the advantages of the safety tube features. In addition, 2 models